Welcome to Trailblazers with Garry, a serious but global health matters podcast. I'm your host, Garry Aslanyan. In this series, I sit down with trailblazers in global health for short face-to-face conversations, which you can listen to in audio or watch the video. It's a chance to get to know the person behind the work, hear their stories, and gain their perspectives on current global health landscape. Join me as we explore the people, places, and ideas driving global health forward. Let's get started. For this episode, I had the pleasure of visiting John-Arne Røttingen at Wellcome. Wellcome is a global charitable foundation in London, United Kingdom. John-Arne stepped into the role of the Chief Executive Officer of Wellcome in 2024. Through his career, he has held numerous prominent leadership roles in health and research, including serving as Norway's Ambassador for Global Health and as Chief Executive Officer of the Coalition for Epidemic Preparedness Innovations, otherwise known as CEPI. In our conversation, John-Arne reflects on his leadership journey at Wellcome, the vital importance of fostering collaborations between citizens and scientists, and shares his insights on the current funding crisis facing global health. Hi there. So I'm here at the building of Wellcome, and I've just met CEO Dr. John-Arne Røttingen, and we're going to have a quick chat. So it's really great that you were able to watch us on video because if you're listening to this on audio, this is a new podcast style we're using of video conversation. So John-Arne, welcome your second Trailblazer in our series of Trailblazers.
Yeah, thank you. Thanks for the opportunity to have this conversation.
Great. So maybe we can start, and we met a really long time ago, and I know you're from Norway and worked in global health. What's in your upbringing in Norway that really made you interested in global health in this area?
Yeah, I guess it's coincidence is probably the most correct way of describing it. Mm-hmm. But of course, there's some drivers, and from me, it's the science drive, it's the justice drive, and it's also the drive to see results of what I do. And in one way, global health is a great combination. I was quite a geek as a child as a youth, interested in computer science, did a lot of programming, did well in school, had inspiring teachers, in particular my chemistry teacher. Did a sort of add-on biotechnology course that was voluntary, and that sort of introduced me to the process of the potentials of biomedical science, which was really inspiring. At the same time, I guess my upbringing, Norway is sort of quite a flat society. Equality is important. I was also quite active. Not in party politics, but sort of politically engaged, wanting justice, wanting equity, and equal opportunities in society. And then my family is really from a small community on the west coast of Norway. My grandfather, I remember, he was a farmer, and actually my parents were the first with higher education in the family, but he wanted me to do something practical. He wanted me to do something study something that could actually achieve results. And in some way, he was disappointed when I decided to not do surgery, which was practical and actually see the results, and more do the public health and the theoretical parts of medicine.
Interesting, because now that you're saying you were from the west coast of Norway, I remember going on fjords cruise along the coast, and you would see houses every, 5 to 10 kilometers. And the first thing I thought about was
how do they organize a health system here? And how does that work? It's so dispersed, right? So maybe public health is just as important in that kind of setting?
Yeah, and in some way also community health. And actually my grandmother, my great-grandmother, and my great-great-grandmother were all midwives in this community and needed to assist on deliveries locally before it was sort of usual to actually do deliveries in the main hospital that were at that time probably 3 hours drive away from the community. So yeah, in some way the rural part of Norway is similar to many contexts we see around the world today.
Right.
And then how do you make sure that people have access to professional support or even educated lay support for health? And if you look at the numbers, I actually did that sometime. So probably my great-great-grandmother then, the maternal mortality, child mortality at that time in Norway
quite high,
was very high,
Yeah.
and not similar to some of the challenging contexts we see in Africa today. So it demonstrates that countries have gone through a phase of development. We just need to make sure that all countries can actually go through this improvement and improvement in child survival and improvement in maternal mortality.
Oh, great. Thanks for sharing that. You had many real leadership roles in your career in Norway and also Global Health Ambassador for Norway. And what is leadership for you in terms of values and how you perceive that role? And of course, now being CEO of Wellcome, what are your sort of approaches to leadership?
Yeah, I think you need to be really committed to the mission of the organization. You really need to emotionally connect and want to deliver because that's, I think, is inspiring for your colleagues. A leader has a special role. I guess I'm by nature seeing leaders on equal terms with the rest of colleagues in our organization. That's another value I have very much sort of believe in. But at the same time, leaders, they play roles, and that role as championing the mission of the organization, championing the values of the organization. At Wellcome, we want to be both thoughtful and brave. So balancing those different values, for instance, is important. But to me, the most important is really this commitment to the mission and actually being able to communicate and inspire that in your organization, but also wider in society.
Right. So if the leader embodies the mission, then that kind of trickles down to the organization through that leadership.
Yeah, through inspiration and through setting examples, I guess. Absolutely.
Right, right. In your first year or year and a half you've been in this position, you've visited a lot of partners in countries in Africa, in Malawi, in Kenya. I heard also in Vietnam and Thailand, where you have work. Why were these visits important? And also, what did you learn in the countries where things are going there?
Yeah, so Wellcome is a global foundation, so we have a global mandate, and we want to support science to improve health for everyone across the world and really make sure that we can deliver benefit to humankind. That's already written in the will of Henry Wellcome when he established the foundation now almost 90 years ago. My thinking was that when I started here, I will be sort of swamped into really focus on the organization, and of course we are situated here in London. It means that it's easier access to the community, stakeholders, research groups here in the UK. So I decided to spend a lot of my first couple of months actually to travel to our major partners in both Africa and Asia, so South Asia, Southeast Asia. And that was really inspiring. I must say I hadn't understood the size of these centers and programs that we fund. around 1,000 staff in several of the locations. Really nice. I came to Malawi, the Malawi, Liverpool and Wellcome partnership there. It's fantastic what they do alongside the hospital and the University for Health Sciences in Blantyre. Henry Mandumba has been sort of going through that program. He came in. He's now the leader. He came in as a student and have gone all the grades. I've been professor here in Liverpool for some time and then gone back and now leading the center. Just inspiring what they do in that society. Another example, Africa Health Research Institute that has sites both in Durban and in Somkele, a bit further up north in KwaZulu-Natal. And combining very advanced lab sciences with population health and really surveying the full community up in Somkele. Emily Wong, for instance, one of the researchers there, doing very interesting work, advanced work on multiomics, understanding immunology, pathogenesis of TB, and in particular in a population, as you know, with high HIV rates. It's a partly a different form of TB, but also more prevalent, and an understanding, for instance, now that we see there is probably quite more actively transmitting TB that is asymptomatic, so in a way silent TB, which has a big impact for transmission. And you may know we are partnering with Gates Foundation and GSK. Gates Foundation and Wellcome funds a large now phase 3 trial on tuberculosis, the M72 vaccine. South Africa is the country where we recruit most patients now for the vaccine trial. And TB is still the most deadly infectious disease in the world, a problem that we have not really been able to handle. Still very, as you know, very long treatment regimes necessary to treat, increasing multi-drug resistance, compliance challenges. So that's why we're really hopeful on potential of actually the first TB vaccine approved in 100 years if the trial is successful. We will know in 2028, so still some years to go. So that's the challenge when doing large clinical trials like that. So those are just a couple of examples, but equally inspiring in Kilifi, where we collaborate with KEMRI and we support the KEMRI program, and in Vietnam and in Thailand, that are more networks of research centers across many Asian countries.
Right. And what about the countries themselves? Do you feel, how did you assess sort of capacities in other parts of the research ecosystem in countries, their plans and all of that? What were your observations about that, where things are going in countries?
Yeah, so I think if you look at the numbers, Africa, if you use that as an example, because it's still the continent that is probably lagging the most behind on many economic indicators. But if you look at research capacities, research capabilities, number of research papers coming from Africa with African lead authors, it's really increasing. And this is across fields, and life science and health is leading among them. So it's a really positive development. I think the centers that we support there are centers that were originally established as partnerships between UK-based researchers that really devoted their lives to research infectious diseases in particular, and challenges in low-income country settings, established these centers and programs in collaboration with local researchers and institutions, but gradually evolved into, as I mentioned, more locally led research institutions. I think the next step that Wellcome should really consider is how we engage the broader research ecosystem in those countries, how we make sure that we engage in a good way with governments. I would want to see governments in Africa taking up more of a research investment responsibility, because that is a necessary part of a pathway to economic development and prosperity and improving health.
Right.
And we could probably do more, and that's definitely an ambition I would have in the coming period. So that speaks to Wellcome being a foundation. And as I often say, is that foundations are not the main sector in society in any way. We need to complement what governments do, and we need to complement what private sector can do.
True.
So we are first and foremost catalytic, and hopefully can initiate things that can then be taken on by the larger sectors, that public sector or private sector.
Great. Interesting observations. Thanks for that. So I think I read somewhere that you said, and I'm going to read what you said, hopefully that I got that right. Science is not enough to change the world. It must be allied with collaboration action across society. Maybe you can elaborate a bit more on that statement, and I think particularly this time where science is being discussed differently, or where we're facing some additional kind of views on science, etc. Can you add more why this approach that you mentioned is important in terms of how science really is aligned with societal goals?
Yeah, no. First, and of course, I've been very engaged in what you can call knowledge translation, or sort of trying to foster that science-based knowledge, new technologies derived from science can be implemented and used, either if it's changes in policies, if it changes in clinical practice, if it's commodities, technologies that needs to be regulated and onto the market. I'd be probably focusing more on that sort of latter part of the scientific ecosystem, if you see what I mean.
Right.
And I believe we definitely understand that science is not enough, and that's why it's so beautiful for me and so inspiring that Wellcome is a research funding organization that has a broader mandate, and we have made a decision to not only be a research funder. We do invest in research, yes, and of course most of our charitable investments go to research, but we also invest in policy work and influencing work that can contribute to making sure that we both have evidence-informed policy and practice, but also that technologies are taken up at scale. For instance, in the global system of health, I think we are so dependent on making sure that policy is sort of future-looking, right, and aware. And then the third sort of way we work is really about citizen engagement, societal engagement, and I think that is even more important than ever. We see challenges related to trust in science and in science-based solutions. For some reason, vaccines and vaccinations have become a sort of a poster child of this mistrust, and we see that in many countries and contexts. We saw it during the pandemic as well. Other public health measures during the pandemic also became quite contested, and I see that as a signal that we need to just double down on trust in science. And then, yes, to build on that and to build trust in science, we need to engage with citizens and actually also tackle problems and issues that are important to people. So that's why it's not only sort of a broad communication strategy on engaging citizens with science, but it's actually how do we want our grantees to do their research when they work on applied research? How do they engage with local? Yeah, exactly. Yeah. And that has been important for Wellcome for a long time, and we are definitely continuing that, making sure that research questions are addressing problems and issues that also local communities see, and making sure that the research community is also representative of communities, and that speaks to the need for diversity and inclusion also in research, and I see those as tools to really delivering on our mission on improving health for everyone.
Yeah, great. So we have a lot of work to do, obviously,
absolutely,
as a global health research community. But global health recently is really experiencing a little bit of a crisis in terms of funding, in terms of a lot of cuts from government sources as well. I also, like probably yourself, have seen people calling for maybe it's an opportunity for us to think about how we do things differently and how we reassess. What, in your view and your experience in global health, that you think worked well and we should continue and do it, and what we should change as we kind of face this new reality? In the last few months, things have changed, so global health will change. And what would you keep and what would you change from that?
Yeah, those are big and really key questions, and we are in a difficult time. I can come back to some of that, but I think I first wanted to say that global health as a system has delivered its very strong results, really, when it comes to population health. If we look at, as we discussed earlier, maternal mortality, child survival, life expectancy, reductions in incidence in the 3 big infectious diseases, HIV, TB, and malaria, and much of that was driven by very dedicated investments and institutional mechanisms and funds and so forth on the MDGs, the Millennium Development Goals. It demonstrates that science has delivered, because a lot of this is science-based solutions, and we can improve global health and global population health. At the same time, I think actually I would say that the pandemic was maybe the first clear indication that the system is not fully delivering what is needed. And of course, we were extremely successful when it comes to a fast vaccine development process, from viral sequence known to vaccines approved in 11 months. At the same time, and actually delivering those across the world and at scale, unprecedented. But at the same time, we also saw the big differences in access to vaccines, and the continent that probably spoke up the most was the African continent, which is very understanding. They had established more of a public health institutional mechanisms, partly coming out of the Ebola outbreak and understanding that public health and infectious disease and health security is a continental sort of challenge and priority. But I'm starting with the pandemic because I think that already indicated a system where there is uneven capabilities and distrust in some way, and I think the pandemic increased in some way decreased the trust between African leaders in health and the global system in some way. They talked very clearly that we need more independence, we need more self-reliance, we need resilient systems, we need local manufacturing capabilities, we need innovation capabilities. So that was maybe the first. And then we saw after the pandemic that the world has many other crises. Of course, the climate crisis was a high priority for many countries, and including what you can call donor countries. And then we unfortunately had the wars in Ukraine and in Israel-Palestine, which both needed resources and attention. So health was already sort of prioritized less from a political point of view coming out of the pandemic. And then with Ukraine, the security situation in Europe, with a new administration in the US indicating clearly that they will focus more on the US needs,
Right.
and America first is the slogan, but actually they want to, I guess, respond to the electorate that elected the new administration and Trump as the president, so they will focus more domestically. This has an impact on the security situation. It means that European countries are now committed to increasing spending in defense, so they will, and some countries explicitly, like the UK, have said that they will move funds from the official development aid envelope to the defense budgets. Other countries in Europe indicating that they will need to cut in development aid assistance. And then the very abrupt changes now, we are around 100 days, I guess, into the Trump administration. The abrupt changes they have done on USAID, PEPFAR, of course has meant that being the biggest global health funder, we have a dire situation with, I would say, most likely a 30-40% cut in external finance for health in the coming couple of years. So these three changes, a call for self-reliance, more independence in the developing countries and in particular from Africa, change in priorities in donor countries, and the more abrupt changes now making this more of a crisis, I think are all leading towards the need to look into the system. So what should we maintain? What should we improve? I think we need to first and foremost see that it's governments that are responsible for the health of their population. So the centrality of democratically elected governments being accountable for health and health care, and meaning that in the poorest countries, when they are supported externally, we need to be more respectful of actually governments being in control, leading national health plans, having one plan and not 30, 40 different plans that we see in some African country contexts, and making sure that the external system for development assistance for health can support those plans and support governments more coherently, and then build up more of a broader primary healthcare based. I talked about my family being midwives, and in communities. I think we need to a health system need to be rooted in communities and in primary healthcare, because that would deliver most cost effectively good health outcomes in the population. And these are some of the shifts that we concluded in the Lusaka agenda that Wellcome was facilitating. I had then another role being ambassador for global health in Norway, and I co-chaired that process together with Mercy Mwangangi, who's now leading the social security health insurance system in Kenya. I think those Lusaka agenda shifts are quite useful actually as strong principles for the changes we need to drive towards. And I think the urgent crisis now is just a burning platform for us for actually moving faster towards a system that is more rooted in countries and governments' responsibilities.
So we have some good indications of where we should go. We just need to act on that and really bring it to life and implement, as all of us as a global health community, really.
Yeah, I believe so, and we probably need to be more devolved. We probably need to build more capacity regionally and locally.
Right.
For us as an institution that supports science, we are strong believers of also building research capacity and doing the research necessary to address the health problems of developing countries in developing countries by developing countries. So we need to double down on that.
Okay. Well, great. Thanks for this conversation, John-Arne, and thanks for joining our listeners. Again, John-Arne Røttingen is the CEO of Wellcome, and we just had a great conversation. So see you next time.
Thank you, Garry.
Thank you for joining me for this episode of Trailblazers with Garry, brought to you by the Global Health Matters podcast. The audio and video versions of this episode are available wherever you get your podcasts. Be sure to visit the Global Health Matters webpage for more information about my guest and this series.